for our body. All right, so we have to have acetylcholine in order to run. All right? So this is the basic chemistry that we're going to be trying to deal with. All right? So by history, how did neuroleptics begin? All right? They were discovered by a Frenchman named Henri Laborie, and he was working with antihistamines to prevent, is it better if I'm here, Janice?
Yeah, you're good.
Okay, to prevent post-op shock. Because patients were dying of shock after they had surgery, not only in Paris where he worked, but all over the world. And he was using antihistamines, why I don't know. But what he found was that those patients who were schizophrenic, who were waking up from surgery, to whom he'd given an antihistamine, were actually waking up with clear thoughts for several hours. No more delusions, no more hallucinations, they were actually thinking clearly. And he found the antihistamines can actually clear a schizophrenic's mind. And he was the first one to realize that we can use medications to change how people think. And this led to the development of the first class of antipsychotic meds, like Clozaril, Stelazine, Mellaril, Navane. And it was great because we had no more crazy people, but they had lots of dangerous side effects. Weight gain, altered glucose metabolism, made them diabetic. They had tardive dyskinesia. We'll talk about that when we talk about antipsychotics. We have newer drugs today that are called new second generation antipsychotics that don't have the same potential to do that, such as Zyprexa, Risperdal, and Abilify. We'll talk about those another week. But that's where it all came to pass. So now we're going to take a sideline. Any questions about where this kind of all began? Okay, and what we're going to talk about. So let's take a little sideline. Let's talk about Selective. And I gave you a little handout, okay? Because I want you to understand all these terms. So if I say, we're going to give this, you hear a doctor say, yeah, I'm going to give them some Lexapro, 10 milligrams QD. Q means every. D is day. So QD is every day. You've got that right here, okay? 2 a.m., right, would be in the morning. PM is PM. HS is bedtime. Q means every. BID is twice a day. TID is 3 times a day. QID is 4 times a day, right? That little A with the line above it is supposed to look like this. And P is supposed to look like that. That's the best I could do with my computer. That's before and after, all right? And I might say 1 hour before breakfast. That's what that little degree sign is supposed to mean. Okay, I could say 1H or 1 hour. It's a little degree sign, all right? This is with, this is without. This is really helpful if you're reading medical notes, you know, that you're getting from a chart. That's why I wanted you to have this, okay? This means time, right? So let's practice a couple, okay? I could say if I were giving, maybe I was giving some Risperdal, okay? So I could say Risperdal, 0.25 milligrams, and then it would say sig on the script, which means signification. That's what I'm signifying I wanted to do, okay? 1 PO, I didn't put that down, that means by mouth, per us, all right? At lunchtime and HS. What's HS? Bedtime. If I were giving an antibiotic, I could say ampicillin, okay, milligrams, okay, I could say, go like this. That means 2. Here's 1, 2, 3. This is so that no one's going to make a mistake with bad handwriting, okay? So what if I wrote like this? This means then. What does that say?
2 times.
2.
By mouth.
2 hours. No, that's before. Procedure. Then.
1 time by mouth. As needed.
TID is 3 times a day.
3 times a day.
As needed, I didn't put on, is PRN. I have been a nurse for 38 years and I still don't know what PRN means. Like what the Latin is. Isn't that awful? But it means as needed. You might see Xanax, right? 0.25 milligrams. Sig. What is this? Xanax, 0.25 milligrams.
One time by mouth as
As
needed.
needed anxiety.
Up to, right. Right? Got a feel for that? I just kind of wanted you, should be more, you got the idea. You got the idea, okay? I just wanted you to kind of have a feel for what all that meant, okay? So you can kind of look it up and know what it was, okay? You might see sometimes like 3 times per day. That's why you see the X. That's what the X would be, 3 times per day. It'd be like that, 3 times per day. You know, there's all kinds of combinations of this. All right. So that's a little bit of background. All right. Now I'm going to just sit where I can talk. Any questions so far? Is that because you're shy or doing such a fabulous job?
When you were talking about the prefrontal cortex with ADD, was that too much or too little?
Too little.
Too little.
Yes, yes. And what we have to do to fix ADHD is give people more chance. Am I in a good place?
Yes, you're in a great place, thank you.
Now you've all got your handouts, okay? And what we're going to start doing is methodically, but hopefully not too boringly, go through all the different drugs that are used. And I'm hoping today to get through antidepressants and tricycles. And then in the next 2 sessions, we're going to talk about mood stabilizers. We're going to talk about benzodiazepines. We're going to talk about psychostimulants. We're going to talk about all the different, hopefully I can get you drugs for dementia. I may or may not get you drugs for substance abuse. I'm putting that very low on my priority list. But one by one, I'm going to go through these classes. And what I'm going to first talk to you about is a class effect. And what a class effect means, every drug in this class causes this problem. All right? There are idiosyncrasies of each drug, but we know that all SSRIs, no matter what they are, have the potential to cause what? What's the biggest problem with SSRIs? Side effect. Yes, yes, sexual. Either diminished libido, erectile dysfunction, or anorgasmia. That's a class effect, right? So I have to tell that when people say, well, I don't want to take Zoloft because it could cause this, and I'm like, honey, any of these drugs can cause it. And when people get worried about these things, you have to be very clear to them that just because one drug in the class causes this doesn't mean another won't. So sometimes I have to try 1, 2, or 3 drugs before I can find a drug that a patient can tolerate well. And I have no idea where to start other than insurance. A lot of times insurance tells me what to do, especially Blue Cross. My hands are tied a lot of times. If you have Blue Cross, you're getting Prozac. Because that's what Blue Cross requires. If you have ADHD and you have Prozac, Blue Cross, you're getting Concerta. Even if everyone in your family takes Vyvanse and does better with Vyvanse, they won't pay for it until you fill Concerta and Adderall first. So, some of my decisions are made by insurance companies. And that's the first thing I look at, by the way, is do you have any family members who've done well on a particular drug? And if they have, that's the first place I go if I possibly can, if insurance will allow it. So, all right, so first we need to talk about Aciphex, and I can see that I forgot to put that in here. So my apologies. Let me talk about class effects of antidepressants. My apologies. I'll have to fix that for next time. So what they do, how they all work. Let's talk about how SSRIs work. I got your neuron, right? This is our presynaptic neuron, right? And here's our postsynaptic neuron. And with regard to anxiety and mood, serotonin is excitatory. We want serotonin to turn on postsynaptic cells, all right? So you've got serotonin made in the cell body, and it's actively transported. It doesn't just meander down. There's an active transport system that actively moves the serotonin down the axon, down the dendrites, and releases it into the synaptic cleft, where it binds on receptors in the postsynaptic cell, thereby turning them on and hopefully creating good mood and decreased anxiety. Now, there is a recycling system. So cells were green long before it was PC. And what the cell does is it tries to recycle any extra serotonin floating around in here so that the cell doesn't have to work hard if not necessary. Okay? And that means there's a feedback loop that tells the cell's brain. And Janice, I'm not using all the markers because it doesn't matter. I was hoping I could have
We'll get you some better ones next time.
Yeah. It tells the cell's brain how much serotonin is in the synaptic cleft, so that in an ideal world, the cell's brain can say, okay, there's too much serotonin, I can downregulate and rest in an effort to conserve energy. Or if there's not enough, it can upregulate and say, okay, I need to gear up a little bit and get more. But sometimes the system doesn't work. Sometimes people were born without enough serotonin in the first place. And these are the people who come to me and say, I have been worried since the day I was born. You know, mothers say that. Timmy has been anxious since the day he popped. How many times do you hear that story, right? Or I have been depressed since I can't remember a time when I wasn't depressed. These are the people who are born with those serotonin levels and who I'm very quick to go to medication with. Because you can do therapy until the cows come home, we're just not going to get them enough serotonin to fill all of these postsynaptic receptors and make them mood good, or their anxiety low. Second time I really go to meds quickly is when I hear a very strong family history. Because even though they may not have been depressed or anxious as a child, if they've got a strong family history, I know there's a genetic predisposition for the system to get out of whack in a hurry. The third is if someone's suicidal. I just don't mess with that. You know, you're going on meds until you get better. I just don't, I take that very seriously. These are safe medications, and by the way, I don't need to check anybody's liver function, kidney function, EKG, like with tricyclics, I have to get an EKG, you know, make sure people are safe after a while. They're very safe. I'd rather have them on medication than risk self-harm, all right? So that's how things are working, okay? Now, what can happen, so here's what happens when we give people SSRIs, okay? We give a drug, because can I give them serotonin? Why not?
Blood barrier.
Right, and by the way, the chemical form of serotonin is 5-HTP, which stands for, I'll put this morning, 5-hydroxytryptamine. Now you know, okay? People often say, well, can't you measure the level of 5-HT in my blood and find out, you know, if I have enough serotonin, because they look things up. And the only way I could find that would be to do a spinal tap, which could be, go back here. Take a needle and stick it in to this space right here. And I could pull off cerebral spinal fluid and measure how much serotonin you have in there. But that's dangerous because now I'm risking introducing infection into this space and giving someone meningitis. So that's not a risk-benefit ratio that's valuable. No one will do that. Okay, so the answer is yes. We could find it out, but it's not easy. We can't measure it in the blood because blood is lipid filled, right? So everything dissolves. And serotonin. And blood's all full of lipid. So, we need more serotonin because we've got empty receptors, right? So what we do is we come in with an SSRI, which stands for Selective Serotonin Reuptake Inhibitor. I have to write that down, right? And that SSRI selectively inhibits the reuptake of serotonin. It only hits cells that are serotonergic. Cells that make serotonin are serotonergic, but what I call a cell that makes dopamine. Dopaminergic. What if it makes norepinephrine? Norepinephrinergic, right? What if we make GABA-aminobutyric acid? GABAminergic, right? It's not as hard as it sounds, okay? So it's going to selectively go to serotonergic cells, and it's going to inhibit the reuptake of serotonin. That's all it's doing. It's getting into this recycling system, selective serotonin reuptake inhibitor, right? It's inhibiting the reuptake of serotonin. And so that now there's more serotonin left in the synapse to bind with these receptors. Cool, huh? But there's a problem. What happens with this feedback loop initially? It tells the cell's brain there's more serotonin in the synaptic cleft, so you can rest. So the cell responds by down-regulating it first. And it takes about 4 or 5 weeks for that cell to go back to its pre-medication level. And that's why we have to tell people, you have to wait a few weeks for these drugs to work. Don't throw them in the trash, because it takes time. Some people do feel better right away. And that's not just placebo effect. Some people's cells, they don't have to re-regulate very quickly. They don't have to re-regulate. It takes them, they just respond right away. But that's what's happening when we give an SSRI. So got that whole process down? All right, so now let's talk about SSRIs. All right, we're going to talk about class effects. All right, so they all block the reuptake of serotonin in the synaptic cleft. We talked about all this. All of them have the potential for sexual side effects that Kelly mentioned with our sex therapist. Sex therapist. They all have the potential to cause dry mouth. Dry mouth is actually the #1 side effect of all meds, no matter what class of meds they are. You know how I know that? Because my husband and my brother-in-law and my father-in-law and my son are all dentists. But dry mouth is a problem because saliva has a cleansing effect. So it's not only uncomfortable, but if people are taking SSRIs for prolonged periods of time and they do have dry mouth, they do need to be seeking dental care more frequently. Make sure they're getting their teeth properly taken care of. If patients, and those are class effects. Now, if you look them up, you'll find a million effects. And I always tell patients, be very careful, don't go online. People who blog are the people who are pissed off. If you look these drugs up, make sure you go on reputable drug sites. Mayo Clinic is a great drug site. WebMD is another good one. But you're going to see a list of side effects a mile long. And then I tell them, go look up Tylenol. Tylenol can kill you if you take too much and go to liver failure, right? So you have to be very careful what you read. When I'm telling you are the major effects and that these drugs are by and large safe. Now the one problem these drugs can cause is serotonergic syndrome. This is where you get a surge of serotonin. And what a surge of serotonin can do is elevate your heart rate and blood pressure to dangerous levels. And it can be fatal, and that would ruin your day. So, any of you who've been in my office, I'm sure see my blood pressure cuff and my stethoscope sitting around. I take everybody's blood pressure, and what I do is when I start patients on meds, I check them once a month while I'm changing their med dosages until I get them on the right dose of the right medication. And then I have them come in every 4 months to get their heart rate and blood pressure checked and to put my eyes on them. And I'm always mind boggled when patients say, no one's check my blood pressure. I think it's very easy for people to sit back and forget that we're still dealing with drugs that have the potential to create harm. It's very rare. I've had it happen to a few patients. Maybe 5 in 15 years, but I've still had it happen. And we have to take care not to overlap these serotonergic drugs so that we don't get serotonergic syndrome. If you give, sometimes they're additive, 1 + 1 is 2, but sometimes they're synergistic, 1 + 1 is 3. It's kind of like alcohol and Valium. It's not just alcohol and Valium, it's like you're dead, right? Prozac is a real offender. I could combine Lexapro and Remeron, but I couldn't combine Prozac and Remeron because Prozac really gives more serotonin surges. This is just a matter of knowing drugs, right? If people stop these medications abruptly, it's not dangerous for them, but they won't feel well. They may feel fluey, achy, icky, but it's not dangerous. You will also see a couple things on packaging. One is that they should not drink alcohol. Now that's tough because a lot of people are going to drink alcohol, and so I'm honest with them. The truth is, they can have a glass of wine or a beer. But what these drugs do is they make you get drunk more quickly. And I'd rather tell patients that than say no alcohol at all, because they often don't comply. You're gonna get drunk more quickly.
How often? A glass of wine?
One night, in a day,
Okay.
one glass of wine. So if you go out with friends, you're a teenager and you're taking Prozac, and everyone's got a beer, you can have a beer, but then maybe fill your beer can up with water or pop, or something. Or I always talk, especially teenagers, with what else can you do? Can you say I'm taking meds and I can't drink? Can you say liquor, I can't hold my liquor? Or can you just have a glass with something in it and just, who needs to know what you're drinking? You have to come up with some strategy, to help people, especially who are at risk, to not be drinking too much. So that is one issue. We talked about weaning. I'm sure something else will come up in my head. And if I do, I'll let you know. Okay? All right, so let's start going through these meds one by one. Okay. First is Prozac. What I've got is the brand name there, and then I've got the generic. And all drugs now are dispensed as generic medications. That's part of our new healthcare system, unless I write DAW on the script, which means dispense as written. Now, usually I need to get clearance from an insurance company to do that, and I usually need a reason for it. And that reason is usually a patient didn't do well on the generic drug. People often ask, are generic drugs worse than brand names? And for many people, the answer is no. But for some people, the answer is yes. So for those people who need it, I write DAW. And for those who don't, you don't, and it's cheaper for them. Okay? But everything is generic now. Prozac. Prozac is the only medication approved by the FDA, the Federal Drug Administration, for depression in children and teens. So if you see me giving a lot of Prozac to children and teens, it's not because I'm not creative. It's because not only do most people have Blue Cross and that's what they insist I use, but I always go with FDA-approved medications first. And that's the only drug approved for treatment of depression alone in teens and adolescents. Unless, I have a young man I saw a couple weeks ago whose aunt, grandmother, and mother are all treated with Selective. So I put him on Selective. And I called Blue Cross and I said, I need a prior authorization, this is why, and I went to that trouble because clearly this is a drug that works well for his family genetics, and he's actually doing really well. It was a couple weeks ago, it was a couple months ago. It's first-line treatment, and any insurance requiring step therapy. Step therapy is when they say you have to try drug A, then B, then C, then D, like you hear Medicare Part D and all these other things, they tell me what I can prescribe. If anyone is taking Prozac, they can never eat grapefruit, ever. Not just with their medication, even when they're not in the medication, it'll just deactivate whatever Prozac level they have in their blood. So no grapefruit juice, even no grapefruit flavored candy. Because some of it has some grapefruit derivative. So it's not a terrible thing to avoid. Most people don't like it, but you have to say it. It's got a very long half-life. The half-life of the drug is how long a drug takes in order, how much time it takes for half of the drug to be gone. And it's not that it goes half-life and it continues to go on the same trajectory. Usually a drug reaches a half-life and then it really trails off. So we talk about half-lives because that's kind of, when you've got your peak performance of a drug and it's going to fall off. Prozac lasts a really long time. And that means that if I've got someone on a high dose of Prozac and I want to switch them to another SSRI, I might have to let the Prozac wash out for a couple of weeks first before I can make a switch. What I try to do is go down on the Prozac and up on the other drug. So at least I always have some SSRI in their system. I'm doing that right now with young lady. I'm switching to an Afrinil. I'm going down on one and up on the other, but I've got her coming in every week for blood pressure checks to make sure she's not getting serotonin. Right? It's not true of any of the other SSRIs. If you're on Lexapro and I want to put you on Selective, you just say stop your Lexapro today and start your Selective tomorrow. Prozac is the only one I have to be careful of. This is really good also for the treatment of anxiety and OCD. My first real hang-up and worry was what drug do I start with? And now I know if someone's got anxiety or OCD, Prozac is a good drug to start for that. And I try to give you the doses of drugs, just so you've got something to go by. It starts at 10 milligrams. It is very standard to start people at 20 milligrams, unless they're a child. So I often start people at 20 because 10 isn't going to do anything anyway, and it's acceptable to start 20. I rarely get to 80 milligrams. Usually if I get to 50 milligrams or so and I don't see any effect, I stop and I either change medications or I add another adjunctive medication, such as a mood stabilizer or, some Wellbutrin, if someone's not anxious, I add other classes of meds that we're going to talk about. Because sometimes I need recipes. The trouble is when you get to high doses of medications, you start getting side effects. So people don't like to take multiple meds. And the more meds you give, the less compliance you have, and the more times per day a person has to take a med, the less compliance you have. I want people taking their meds, and that means I have to try to avoid side effects. So that's my commercial for going to multiple meds instead of high doses of one medication, just to avoid side effects. And it really should be taken at the same time of the day. That doesn't mean you have to wake up and take your Prozac at 8 o'clock every day. It means take it when you get up. Now, if you're a teenager and you sleep till 2 in the afternoon, that might be a problem. Maybe you better take your Prozac at bedtime, at dinner time. But put it somewhere, have your patient put it somewhere where they're always going to see it. Like, I always brush my teeth in the morning. What do you do every day? You always put on your pot, you always make your pot of coffee, put it on top of a coffee pot. Just put it somewhere, and this goes for any drug, where you're going to be reminded to take your medication, all right? And this can be taken with or without food. I usually tell people to take it in the morning if they find it makes them tired. They can take it at bedtime. It really doesn't matter, as long as they take it at the same time, around the same time every day, and they don't take it with the grapefruit. Okay? Any questions about Prozac? All right. Zoloft, known as sertraline, is the only medication approved by the FDA for OCD in teens. So now if I have a teenager who has OCD, I've got two choices. I can do Prozac or Zoloft. Still not approved for the treatment of depression. I use it all the time. And that's called going off label. Because what if I give Prozac to a child and they don't do well? Do I say, well, sorry, nothing else is approved? Sometimes I give these drugs to children and they do worse. That's called the paradoxical effect, right? It happens. By the way, you're going to hear a lot of parents tell you, I went online and I read, or there's a black box label that children and teens who take antidepressants have a higher rate of suicidal behavior. So let me speak to that for a moment. There was a huge study done in the UK that looked at Paxil, which is an SSRI, about 10 years ago. And they found a statistically significant increase in the number of suicide attempts in teenagers who were taking Paxil. So we stopped using as much SSRI in kids and teens. Guess what happened to the suicide rate? Went up. So it became very clear that we were doing a disservice by withholding these meds. And we decided, whoever the research took to take a second look at the Paxil study and found that the researchers allowed children and teens into the study who had pre-existing suicidal behavior. And when children were suicidal, they did not sort out if these were the kids who were suicidal before the study or during the study. So it was rather junk research in that regard because they really did not maintain good scientific control. So the black box label maintained as a CYA tactic. I have never had a child become suicidal when I put them on an SSRI. I have had plenty get worse. And I've had plenty of adults get worse too. And I tell that to parents. A lot of times people just don't like the way they feel.